SwipeRx.
Hello, good afternoon, everyone. Welcome to the webinar today, organized by SwipeRx with the collaboration with P&G Health. My name is Wengkit. I'm a registered pharmacist and pharmacist trainer from Alpro Pharmacy. Today, we'll dive into this topic, peripheral neuropathy, unmasking the silent epidemic. Before I begin the presentation today, let me do some housekeeping rules. These are the following are the webinar house rules. Please mute your microphone throughout the webinar and place your question in the Q&A chat box, and the moderator will gladly raise them during the Q&A session. Please attend the full webinar and fill up a feedback form after the webinar in order to claim your certificate. For any questions or concern, you may email SwipeRx team at hello@swiperxapp.com, and they will gladly assist you. The agenda for today, for my part, will be distributed into three parts. The first one, prevalence and burden of peripheral neuropathy. The second one, causes and risk groups of peripheral neuropathy. And we look at the evidence whether the nerve regeneration is possible. Diabetic peripheral neuropathy. So by its definition, is the presence of symptoms and or signs of peripheral nerve dysfunction in diabetics after the exclusion of other causes. It will manifest in somatic and autonomic parts of peripheral nervous system. And very often we start at the toes and feet, gradually move upwards proximally. Most of our customer or the patient will feedback to us that they start to feel the sensation disturbance, or they feel some unusual feeling around the feet area. After being established in lower limbs, it affects upper limbs as well, with sensory loss in a glove and stocking pattern. It means that around this glove and stocking pattern, you feel more discomfort for this peripheral neuropathy. Following up, we go to the prevalence of peripheral neuropathy. So basically, it's defined by monofilament from 2 US cohort. So according to this table over here, so it's very simple for us to interpret, is that we can see that when the patient they are having diabetes for more and more years, the adjusted prevalence of peripheral neuropathy will only increase only. Just for example, we look at NHA, NES, 40 to 69 years old. We can see that diabetes less than 10 years and diabetes more than 10 years makes a very big significant difference when we look at the risk of getting peripheral neuropathy up to 31.5%. Following up, many diabetes actually suffer from DPN or even become neuropathic pain after a certain period of time. For DPN, all patients with diabetes are actually at risk of developing DPN, and up to 50 of them actually will do so. So imagine that, let's say we are dispensing 10 customers with a diabetic medication today. Within certain years, you can see 5 of them will get the DPN symptoms. For neuropathic pain, is a more severe part where 34% of diabetes will get an neuropathic pain. So the prevalence of NEP, neuropathic pain, is higher in type 2 versus type 1 diabetes, more common in women and also South Asian population. So also quite fulfilled our either Malaysia or Singapore population. Okay, in type 2 diabetes women, the risk of neuropathic pain is actually higher, up to 34%, means 1 out of 3 patient or customer will experience the neuropathic pain. It is estimated that at least 200 million worldwide could currently have DPN. So it's a very common issue. So what are the consequences of having peripheral neuropathy? The first common symptom is the numbness. So mostly occur in upper and lower extremities. Patient may not notice injuries. So let's say a small cut as a foot. So it's very dangerous for them. So maybe they just walk around their house barefoot. They got a minor cut, but they didn't realize it because it's numbness. So let's say then the bleeding might become more serious and subsequently has a risk of getting infection. The other issues like diabetic foot syndrome can also lead to a long and difficult treatment or even amputation. For second one on dizziness, Dizziness is actually quite typical but indirect symptom due in the newly stage of neuropathy where customers don't really know is it related to neuropathy, but the answer is yes. Due to the numbness in the feet, neuropathy patients can feel dizzy because they do not feel the ground. Dizziness can even provoke imbalance and force, which can lead to fractures. Another symptom is allodynia. Allodynia is defined as pain resulting from a stimulus that normally does not lead to a painful response. Can lead to sleep issue as the bed sheet hurts. The third part is the pain triggered by a light touch. Symptoms of neuropathy are worse at night. A common issue in patients with advanced neuropathy is they cannot bear the blanket when they go to bed because it's hurt. This is a very classical symptom of allodynia. Diabetics may have difficulties describing their symptom properly. So when we talk to our customer or our patient, right? So we don't really ask them what nerve problem they have because they don't really understand the word like nerve problem. So we ask them to describe the experience. So we ask them, do you have any difficulties in performing activities such as buttoning your shirt, opening a toothpaste tube, or opening a water bottle? I sometimes feel a pricking, tingling sensation, so we ask the customer. We ask the customer whether they experience pain from something that shouldn't be painful. Is one of the symptoms of allodynia. Next, we ask the customer, are you feel like you are wearing an invisible glove or socks that stop them from feeling the touching? So it's like they can't really feel because of the numbness. We also ask the customer whether they experience any sudden pain or electric shock-like pain in their feet or finger without any reason. If we ask them, do you have any difficulty in grabbing any object tightly? Or sometimes they grab the item and they will accidentally drop it. Do they have any lack of strength in their hands or legs? They are not able to sustain certain weight because it's like maybe they can't hold something for a longer period of time. Do they feel tingling or blinking or sensation? It's like an electric shock or some ants are crawling on the skin. So these are also one of the symptoms of this peripheral neuropathy. When we ask them, when you assess, you will touch something, right? It's hot or cold, right? So do they have any difficulty to assess whether the thing is cold or hot? So these are the experience that we can ask the customer to tell us. So we ask the customer as well, so many questions, then we can get somehow the diagnosis of the peripheral neuropathy. So generally, how long does it take to be diagnosed with peripheral neuropathy after experiencing the symptoms? Actually, there's no clear answer. It can take weeks to months or even years after experiencing and noticing the symptom. Due to the nature of the disease, symptoms develop slowly and often go unnoticed by a patient for a long period of time. Onset of numbness is poorly documented and can be estimated only. It's not known how long patient may have symptoms before noticing or reporting it. Peripheral neuropathy often begins asymptomatically and patients don't know about it in the beginning and don't notice any sign. So basically, they're very hard to judge or to decide when, after they're getting the numbness, they will get peripheral neuropathy. So on this degrees progression, right? So the patient may experience mild to moderate peripheral symptom like tingling, numbness, pins, and needle as a mild degrees. After a certain time, you become moderate. Like, for example, they can feel burning or allodynia of peripheral neuropathy or acute neuralgia. In serious period, you progress to neuropathic pain. Patients experience chronic neuropathic pain like harmful diabetes peripheral neuropathy. The pain is unbearable and persistent, so it's a serious condition. Neuropathic pain is difficult to treat and significantly impacts the quality of life. So neuropathic pain can develop if peripheral neuropathy is not properly managed because due to a difficult to treat because of the resistance to medication. Patients with severe neuropathic pain have a much lower health-related quality of life than patients without pain or with mild painful symptoms. The impairments can be due to pain itself, impact on daily functioning in life, quality of sleep might be affected, and due to the anxiety and depression level. Perception from patient. So this is actually one of the survey that carried out previously that we asked the perception of patient, what are the consequences of having this peripheral neuropathy and which one is the most prominent. In Malaysian population, there are more comment on the serious to very serious impact on the quality of life because they will affect the sleeping problem, reduce the ability to perform exercise, and also getting anxiety issue. How about Singapore population? Singapore population, including reported the symptoms including depression, reduced ability to carry out normal duty at work. These two are more common. The burden of peripheral neuropathy comorbidities when peripheral neuropathy progress into neuropathic pain. The one very common and serious one is depression, with a prevalence of approaching almost 100%. Sleep disturbance is the second one. Patient always reported difficulties in sleeping after initial onset of pain, and the onset and the aspects such as hour of sleep, numbers of wakefulness at night, and time awake after sleep are obviously affected in patients with chronic pain. The third one is anxiety. Anxiety represents an independent dimension of mood disturbance apart from poor sleep. DPN can have severe consequences that can even lead to death. Despite this dramatic number, right, you can see that DPN is still underestimated under diabetic complication. So there are approximately 1% of people with diabetes suffer lower limb amputation at certain stage of life. You can see that in patients with DFU and amputation, 73% might have a very high mortality in 5 years. Diagnosis of peripheral neuropathy and is an unmet need. The diagnosis actually should be made as early as possible to prevent further progression of disease or even the development of comorbidities. But already the struggle starts here where patients sometimes do not notice the symptom at the beginning. Patients are not really disturbed by the symptoms and just accept them or get used to them. Patients do not believe the symptoms are anything serious and they don't really see a doctor for that. Patients are afraid of being sick and hope the symptoms will just disappear. So without any previous diagnosis, right, patient will link it to aging. They may feel that, oh, I'm old already, so maybe I have this nerve symptom. It's okay, it's normal. For different reasons, patients actually do not consult a physician and get diagnosed in time. Following, I will present on the causes and risk group of peripheral neuropathy. Peripheral neuropathy can have multiple etiologies. Diabetic neuropathy, neuropathy induced by smoking, neuropathy after the bariatric surgery, carpal tunnel syndrome, alcoholic neuropathy, idiopathic neuropathy, HIV-induced neuropathy, and neuropathy induced by vitamin B deficiency. These are actually there are many causes that could cause the peripheral neuropathy. So how do we identify a typical diabetic patient at risk of peripheral neuropathy? The first one will be related to disease, like for longer duration of disease, hyperglycemia for a longer period of time, high glycemic variability, as the blood sugar can go up and down, insulin resistant or hyperinsulinemia, pre-diabetes, hypertension, dyslipidemia, obesity, metabolic syndrome, and metformin treatment. Part 2 will be on the demographic factors, higher age. Third one, we look at the lifestyle of our customer or the patient. Smoking, alcohol consumption, low physical activity, all this will affect the peripheral neuropathy. Other potential risks and contributing factors, increased mean pellet volume or insufficient multivitamin intake like B vitamins, vitamin D can also cause peripheral neuropathy. Growth factor depletion, inflammation, inflammatory disease, and other genetic factors can also cause diabetic patients to have a higher risk at peripheral neuropathy. Other risk factors including, like I mentioned just now, are the external injuries, trauma, smoking, alcoholism, metabolic nausea, and diabetes, toxic nausea in chemotherapy. Nausea meaning it's a harmful agents over there. Then we have deficiency in multivitamins, like for example, B vitamins, genetic causes, and there are other unexplained causes as well. Drug-induced peripheral neuropathy. So as a pharmacist, we need to aware that some of the drug may cause temporary or a more prominent harm to our nerve. The following active ingredients might cause peripheral neuropathy. For example, antibiotics like isoniazid, metronidazole, some of the anti-gout agents like colchicine, anti-inflammatory drugs like Dapsone, anti-arrhythmic drugs like amiodarone. Many of the chemo medication also affected our nerve. Lipid-lowering medications such as statin and some of the antiviral medication also affect our peripheral nerve. In every third patient, diabetes is the cause for peripheral neuropathy. So we look at this distribution, 34.8% of the diabetic patient will get to peripheral neuropathy. Okay, these are the etiology. Diabetes peripheral neuropathy is a complication of diabetes mellitus. So did you know that actually up to 50 to 66% of diabetics have diabetes peripheral neuropathy? It means 1 out of 2 customers or more than 1 out of 2 is actually having this issue. The longer people have diabetes, the higher the likelihood they get neuropathy. So let's say they're having 5 years of diabetes or 10 years. 10 years definitely having higher risk of neuropathy. Approximately every 12 person with diabetes, 8% have neuropathy at the time of the diabetes diagnosis. So when they're diagnosed, it's already having the neuropathy symptom. The prevalence of neuropathy is approximately twice as high in person with pre-diabetes than otherwise healthy person, and it doubles again in patients with diabetes. So we cannot underestimate the risk of peripheral neuropathy. Hyperglycemia is not the only factor to be considered in diabetic peripheral neuropathy. Hyperglycemia, increased glucose level, promote generation of advanced glycation end products, will lead to oxidative stress, and all this will harm our nerve. Deficiency in vitamin B. Several mechanisms have been proposed that deficiency in these vitamins will cause the development of DPN. Impair endothelial function. Hyperglycemia also leads to a number of negative intracellular events that promote endothelial dysfunction. So when the endothelial function is disturbed due to the diabetes, will also affect the nerve. Hyperhomocystinemia. High homocysteine levels are involved in the development of DPN as well. Hyperglycemia is not the only factor to be considered in diabetes peripheral neuropathy. Most common other causes for neuropathy, including neurotoxic medication, alcohol abuse, vitamins B, renal disease, chronic inflammation of demyelinating neuropathy, inherited neuropathy, and vasculitis. So vitamin B deficiency are additional risk factors for diabetes. So very frequently, diabetes are deficient in all 3 neurotropic B vitamins like B1, B6, and B12. Following, about 14 to 19% of patients treated with metformin are reported to develop vitamin B12 deficiency. Third, vitamin B12 deficiency is among the most common causes contributing to peripheral neuropathy in this population. Elderly patients are particularly at higher risk, commonly caused by low intake or malabsorption, and often occur in people living in home care with increasing age and common in person with bad teeth condition, and it can be triggered by reduced kidney function. The prevalence of peripheral neuropathy increases with age. A remarkable percentage of patients has actually idiopathic neuropathy, which means that the cause of neuropathy cannot be identified or unclear etiology. So sometimes the diagnosis is very difficult for doctors, for patients or pharmacists, because there's no reference to watch out for neuropathy. But they can be diagnosed effectively once we ask the correct questions. Is nerve regeneration even possible? The answer is yes. Nerve regeneration is a natural process that takes place continuously in the PNS when nerve get damaged. But we need to be aware that nerve regeneration is only possible when less than 50% of the fibers of the nerve tissue are damaged. And this we call as a point of no return. When the damage is more than 50%, it's not really that possible already. That's why there's a permanent nerve damage to certain parts of the body. Therefore, the cause of nerve damage should be diagnosed and eliminated as soon as possible. So what does this picture mean? So when the damage begins, right? So only a few nerve is damages, and the repair is actually still very possible or very likely. So when the damage progress, right? So half of the nerve fiber damage, and we have maybe half of the healthy and damaged nerve. There are times still possible to help. However, when there's too many nerve fibers damaged, more than 50%, the regeneration is very hard. However, please note that the point of no return is not a measurement value. We don't know the values like it's like 50, your nerve still have 50% health. We can't actually measure by that. Okay. This only can be evaluated by a doctor who carefully monitor the patients. Mature neurons of the CNS cannot be regenerated. Embryonic CNS neurons are able to regenerate, but they lose their potential during the maturation. Hence, in adult, the mature CNS neurons suppress the regenerative transcriptional program and are partitioned into axonal and detrendering fields, so they cannot regenerate. So just to make this more simple is that in adult, the mature CNS neuron actually cannot recover after the damage. However, for PNS, actually still possible. Neurons of the PNS can be fully regenerated. Like I mentioned just now, it's less than 50%. If the damage is not more than 50%, it's still possible. After injury of a PNS neuron, Schwann cells control the recovery. These Schwann cells will replicate and modulate the subsequent immune response. And after the injury of the nerve, the cell body will swell and the nucleus will shrink due to increased metabolic activity. The axons will form a growth bud and sprouts toward the periphery. The growth rate is up to 1 mm per day. So if the nerve cell body is damaged, regeneration is also not possible. Only axon and the myelin shaft can regenerate. Okay? So I repeat, this part is that when the nerve cell body is damaged, regeneration also not possible. Only the axon part and the myelin shaft part can be regenerated by certain method. So how this can be monitored? Unfortunately, accurate specific monitoring of nerve regeneration is still not possible. So how do we assess this is that we can ask the patient on the symptoms or their improved outcomes or test on the muscle. Electrophysiologically studies may also help for this condition. Imaging of nerve regeneration is not really used in the clinical practice, okay? But it can be, maybe our future, maybe we can do this. In order to prevent the nerve permanent damage, right? So we need to do very early diagnosis and the treatment is really important. How to measure the nerve damage? The nerve conduction velocity can detect large nerve fiber dysfunction actually. So for an example, a healthy nerve, let's say it's like aeroplane, they can conduct the conduction of the nerve very fast. However, when it's already injured already, so the nerve conduction will become very slow, like you are riding a bicycle. So we measure the nerve conduction velocity before and after the treatment might be one of the factors that we can consider to see the response of the treatment from a customer. So to study the nerve conduction, 2 electrodes are placed on the skin along the nerve, and one stimulates the nerve, the other will measure the response and determine the speed. Basically, it's mainly to measure the function of peripheral nerve, large nerve fibers, but they cannot assess small sensory fiber damage. How to measure the nerve damage around our eye area? So when all of us know that, let's say a diabetes patient is very serious, they will have this eye issue, right? So they can't really see well because the nerves are damaged. So in healthy nerve, right? So there are many corneal nerve fibers. When the corneal nerve are damaged, so the corneal nerve will become lesser. So we have this method called corneal confocal microscopy. It's not really that common, but it's very good for our information and also our explanation to customer. So we can detect the small nerve fiber, the eye area, but you require a specialist equipment as well. So the conclusion for this part is that the nerve regeneration is actually possible if less than 50% of the fibers of the nerve tissue, point of no return, is damaged. The point of no return is not a measurement value, just can be estimated by asking customer questions or we monitor the customer closely. In contrast to neurons of the CNS, neurons of the PNS can fully regenerate as long as the nerve cell body is not damaged. Only axons and myelin shaft can regenerate. Next, we move to a simple part on the screening. So basically, referring to specialists is very important when there are many different complications or the disease of the nature of the peripheral nerve neuropathy progress rapidly. Diagnostic tools actually range from simpler to more complex. So actually, there are many diagnostic tools in the market, and it may not work well for all the patients. So it's not really easy, or we can decide which one is best for the customer. So they are like screening tools like questionnaires, assessment tools, pain-related reflex, pain-related evoked potential, skin biopsy, or functional neuroimaging. So some of them can be done by pharmacy assessment, must be done by a specialist. Questionnaire that can be easily used is primary care, like in pharmacy setting. So questionnaire are often used as screening tools or rating scale that are filled based on patient own assessment. The advantage is that it is very easy to use, available online to physician, can improve the diagnosis and thereby treatment of peripheral neuropathy. The disadvantage is that it's quite subjective for customer and it may not work for every customer and only for screening but not for diagnosis. How to diagnose peripheral neuropathy flow from this Southeast Asia expert recommendation. The first one, we classify the symptom based on onset information, acute, subacute, or chronic. Second, we take a careful medical history and ask the patient about their underlying disease, their current medication, any disease history previously, any contact with a toxin or any harmful material previously. Then we assess the symptoms and ask patient proactively about where you have the numbness, how long it begins, do you feel any needle sensation, can you hold the hot cup properly, can you carry something, just like all the questions that I mentioned to you just now. Do they feel any electrical shock or pain, like stabbing or what? Use a picture square every day. For example, like, do you feeling of ends of electric shock? I think this one is more relevant to our customer. Or we can ask the customer to choose what symptom they have actually. Further on, we can perform a neurologic examination with easy and quick sensory tests. So there's something called vibration perception testing, tuning fork, okay? Or the other pinprick test, okay? But if these two are not on hand, then we can use things that we can get grab from the pharmacy to test patient whether they can feel it when you touch a certain area. Then we can order a lab test or to support for diagnosis or do referral appropriately. For the underlying issue, we don't only treat the nerve, we also check the customer whether they are diabetes, what are the glucose or HbA1c level. Then we look at the ESR rate, look at the liver, renal function, and etc. Okay. So that's end from my part today. So for next, we'll proceed to the Q&A question after 3 speakers. And next, I would like to introduce the next speaker of today's webinar. Miss Gina, are you over there? Let me introduce our next speaker, Miss Gina. So it's actually really my pleasure to work with her again today, Miss Gina Khoi, the founder and managing director of City Wellness Pharmacy since 2007. Gina has been a leader in community pharmacy and healthcare in Malaysia. She holds a Bachelor of Pharmacy from Curtin University, a graduate certificate in evidence-based complementary medicine from the University of Queensland, and an integrative nutrition health coach certificate from the Institute of Integrative Nutrition in New York. Gina's exceptional work has been recognized with the 2023 Federation of Asian Pharmaceutical Association FAPA Community Pharmacy Section Award. She also served as council member of MPS Malaysian Pharmacy Society and the advisory board member for the Pharmacy Board Malaysia. Beyond her professional achievement, Gina is a dedicated speaker and trainer, frequently invited to share her expertise at national and international conferences. Her passion for advancing community health and pharmacy practice has inspired many and continues to make a significant impact on the industry. Please join me in welcoming Miss Gina Khoi.
Okay. Good afternoon, fellow pharmacists and friends. Thank you, Wenki, for the introduction. Thank you for tuning in into the second topic for today, pharmacists on the front line, counseling and referral for peripheral neuropathy. So my name is Gina Gui. I'm the community pharmacist and also the founder of City Wellness Pharmacy, which is based in Penang, Malaysia. So today I'm grateful to be here to share with you on this topic, thanks to P&G Health and also SwipeRx. So without further ado, let me dive into the topics today. So as you can see, there are 4 areas that I would like to discuss with you today. So the first one is actually on B6, vitamin B6 safety deep dive. Diving straight into the B6 by itself, okay, specifically. So I'll tell you why shortly. And then secondly, pharmacist counseling points. This is the part where I share the insights as a community pharmacist as we face many patients daily from all walks of life or even from phone calls. So what you can do as a community pharmacist for the counseling, or when you encounter a patient who really needs your advice on peripheral neuropathy or on vitamin B1, B6, and B12. Okay, so when to refer to a doctor, this is a part when the line is drawn, all right, when community pharmacists need to refer to a doctor. So finally, the case study part, this is a part where I share some real life stories on 4 patients, okay, who will probably need extra help on the vitamin B1, B6, and B12. So this part, vitamin B6 is also known as a pyridoxine. It is a water-soluble vitamin. It is an essential for many biochemical processes in the body, right? And its safety profile has been subject to various studies due to the concerns about the potential toxicity at a high dose. So that's why today we just want to discuss specifically on vitamin B6. So what are the functions of vitamin B6? Okay, this is there are 5 areas. Okay, the first one is actually on amino acid metabolism. So vitamin B6 is actually essential for the metabolism of amino acids. It is actually the building blocks of proteins, and it helps the conversion from amino acid to one to another. And secondly, for neurotransmitter synthesis, vitamin B6 is actually involved in the synthesis of a few neurotransmitters, such as the serotonin, dopamine, gamma aminobutyric acid, which is the GABA, and they are actually very important for the brain function and mood regulation. So hemoglobin production wise, vitamin B6 actually play a role in hemoglobin production. As you can see, it is very important for oxygen transport in the blood. So immune function wise, it supports the immune function system by aiding in the production of antibodies. And finally, the cognitive development. It is important for brain development and function, especially during the pregnancy and also infancy. So you can see vitamin B6 is very important, but it has its downside. Okay, that's why today we're here to discuss a bit more on vitamin B6 for my first part. So you probably ask me, where can you get vitamin B6? Well, I suppose that we eat every day. So these are some food options, okay? So poultry, fish, organs, meats, potatoes, and other starchy vegetables, including non-citrus foods, fruits, fortified cereals, such as you can see, those muesli, or all those famous brand or Kellogg's brand and so on, okay, fortified cereals, all in boxes, and they are mostly processed food. And supplements wise, you probably get them from multivitamins or some other nutrition drinks, energy drinks, and so on. So from food wise, okay, there is a RDA, it's called Recommended Dietary Allowance. So you can read from this screen here that adults, okay, that's, I mean, we're all adults here, 19 to 50 years, in fact, 1.3 milligram per day. And then men, which is older, need a bit more, 1.7 milligram per day. Women, well, I'll say compared to normal adults, need about 1.5 milligram per day. Pregnant women actually need slightly more, 1.9 milligram per day. Breastfeeding women need even more at 2 milligram per day. So how does this apply? So if you say, example, a serve of salmon, 100 gram of it, may give you about 0.6 milligram of vitamin B6. And then if you have 1 cup of boiled potatoes, okay, it will give you about 0.4 milligram of vitamin B6. So if you take a meal which contains maybe 2 pieces of this 100 gram of the salmon with a cup of boiled potato, that will basically fulfill your needs of vitamin B6 in your diet. So as long as you eat, don't go on starving mode and all that. So if you eat enough portions, you can get enough of vitamin B6. Okay, even though we get B6 from our diet, but unfortunately there are cases where we have a certain problem, right? For example, I'm talking about peripheral neuropathy today. So that's why the supplements come in where vitamin B6 is generally very safe, as you can see, when consumed according to your dietary allowances, because it's water soluble. rapidly metabolized and excreted. Excess amounts are typically excreted into the urine flow. But unfortunately, there are some side effects. Okay, if you take at the recommended doses, okay, in food and all that, they are okay. They are low risk. But if you take high doses, for example, above chronic doses of vitamin B6 at usually above 100 milligram a day, okay, there are studies, okay, their character can lead to again neuropathy also, okay, characterized by nerve damage that may cause pain and numbness in the extremities. So I mean, the good thing about this is if you have chronic doses at the recommended doses by maybe doctors and all that, if you experience, okay, if some of your patients experience this, you may discontinue it, okay, even though at high doses, if they experience symptoms of toxicity and all that, you just stop it and you just go back to normal. So sometimes some people may say that, oh, with high doses I have this gastric issue. Yes, it's quite common according to study, right? Gastrointestinal symptoms such as heartburn and so on, it's quite common, right? Okay. So what is the tolerable upper intake? Just now I mentioned about is actually set at 100 milligram per day, right, to prevent the neuropathy. But if any doses higher, okay, you may see certain doses like you take up to 500 mg or more. That's the time that you actually need to supervise it. And normally I'd say the doctor will actually definitely recommend it and have to supervise it. So I'll tell you more, okay, as a pharmacist, what we can do. Drug interaction wise, there are three areas, okay. First one is actually levodopa, where the levodopa is normally used in Parkinson's. Okay? Vitamin B6 can decrease its effectiveness unless taken with levodopa. So this is more for Parkinson's cases. You just have to be very careful. All right. Secondly, phenytoin and phenobarbital, they commonly used in epilepsy. So vitamin B6 can decrease their serum level. And the third one is theophylline. It is commonly used for asthma. Vitamin B6 potentially can occur and require a supplementation. So these are the three areas. Just be very careful on the drug interaction part. So as pharmacists, if you have patients who have comorbidities or call it a rare disease, make sure you screen their prescription first before suggesting any vitamin D in higher doses with them. So this part, okay, I'd like to bring your attention to certain fact sheets on vitamin B6 toxicity, where from food source is actually generally safe. But for vitamin B6 in supplements form, you need to be extra careful as chronic administration of 1 to 6 grams of vitamin B6 consistently for 12 to 14 months may cause serious and progressive sensory neuropathy characterized by a condition called ataxia. Okay, means the loss of control of bodily movements. So the body may shake, and it may just lose control if you take high doses for long term. So it is quite dose dependent. Once you stop it, the symptoms may actually disappear. So other side effects such as painful or disfiguring of dermatological lesions, photosensitivity, and gastrointestinal symptoms such as nausea and heartburn, which been highlighted earlier also. So there's one case study, okay, this part here, I'd like to highlight on, it mentioned about the neurotoxic effects, okay. The dose could be as high as 500 milligrams daily to bring on the peripheral neuropathy. So on this study, he actually mentioned that, okay, I'll tell you shortly, how long you can take vitamin B complex, how long is safe, and is it safe for long term or what, what's duration and all that. Just remember that if it's B6, you just look at your, any boxes of B complex, talking about B6 and you calculate your dose, okay, this one tablet is 200 milligram, you just calculate from there, okay, shouldn't exceed that for toxicity. Okay, this part here is actually one study, all right, it's quite a busy slide, but I'm just going to tell you that again, there's one study to highlight the long-term safety profile, okay, for neurotropic vitamin B1, B6, and also B12, where B6 is highlighted on the duration. Okay, if short term, okay, less than 6 months, all right, it is recommended. So if it's more, okay, if it's longer than 6 months, it should be closely monitored by doctor or call it other healthcare professional. So so again, if the person has already got neuropathies and prescribed for long term, it's actually not recommended because of the neuropathy effect, ataxia and so on. So it should be cautious okay? Because if you're gonna take for long term, like some suggest 6 to 12 months, but then it's really you need a regular monitoring. Okay. Okay, I want to highlight to you on this systemic review. Okay, there's one systemic review on vitamin B1, 6, and 12, right? Where B1 actually is quite safe. Okay, no reported side effects, but only through parenteral supplementation administration. Okay, the common ones for B1 is actually associated with diabetes, okay, and also sometimes hypersensitivity reaction, okay, and the review states that vitamin B6, if you have the dose under 500 mg, well tolerated, but if it's more, then that's how the issue will arise. Okay, then in this systemic review, vitamin B12, no effects, okay, no side effects on overdosing, even at a higher dose, for example, 500 to 1000 microgram, even for up to 7 years. So this is actually a report, okay. It said that the council, which is responsible for nutrition in the USA, concluded that vitamin B12 has no observable side effects at any level of oral intake, and there was no basis for a lowest observed adverse effect. They call it LOA. Yeah. So this is the long-term safety profile. Okay, you can have a look. Okay, just now I mentioned to you that I'm just going to tell you on how long you can take the vitamin B6. There may be question on this. Okay, some will say that if I take B complex, B1, B6, B12, whatever, because the person may have long-term issues. Is it okay? Okay, so in this guide, okay, it did mention that if you take 50 milligrams of B6, specifically on just a B6, can be used for long term, as long as the person is still alive. If this 100 milligram, okay, can be well tolerated for up to 5 years. Of course, some will say that why should I take for 5 years? But in the community pharmacy setting, they may not have that care where you have to look at the person for caring. It's hard to say for 5 years. Some will say that I don't want to take for long term. Once I'm recovered, I don't want. But of course, your cases like diabetes and also on, you may be chronic. More than 5 years even. So 100 milligram is still safe. If you go up to 200 milligram, okay, just look at tolerated for 200 days. Okay, 200 days is actually calculate for probably like 1 year, 365 days, or slightly less than that lah. So it's 200 milligram. It's still okay. But if you duplicate the tablets, okay, to up to 500 milligram, okay, because you can't find any B6. One tablet has 500 milligrams. Normally in the lower doses, but you just duplicate the tablets, right? So if that's the case, but less than 200 days. Okay? So if it's more than 200 days, I would advise just have to speak to your doctor, okay, to the patient's doctor, or just collaborate with the doctors and discuss, how we should monitor for safety and efficacy of this vitamin B6. Okay? So you probably ask me why B6, why you keep repeating this B6. So this is a mechanism of toxicity for those who like mechanism. Okay, you can read up more about this. Okay, there's a study which tell you a bit more. Okay, pyridoxine induced neurotoxicity. High doses of pyridoxine can cause sensory neural pain. So this toxicity is believed to stem from pyridoxine competitive inhibition of the active form called doxal 5-phosphate PLP, leading to symptoms similar to B6 deficiency. So it's actually you take more cause the problem. Okay? But if you have less, then you have to take more. That kind of thing. So you just have to beware of this. Okay. So for this one, in conclusion, so vitamin B6 is generally safe to take in the recommended doses. High doses, especially above 500 milligram per day, can actually lead to neurotoxicity and other side effects, and really have to see in individuals. So monitoring and adherence to dosing recommendations are crucial to minimize the risk. Okay. So I finished the first part on the vitamin B6, okay, on the deep dive. Okay, there are many clinical studies to prove to you, that you should be, as a pharmacist, you should be really, really careful, okay, on doing that. So this is the second part where I'd like to share with you on the 6 key areas as a pharmacist, community pharmacist especially, what you can do, okay, on counseling. There are 6 areas. The first one is actually on purpose. The second is dosage guides, side effects, interactions, signs of deficiency, and also monitoring. Okay. So the first one is actually on purpose, right? Well, during a counseling session, you can inform the patient that for nerve health, support the nerve health. Just now, Winky has actually told you, on peripheral neuropathy, what are the possible patients, okay, who has this problem. So for nerve health, first thing, support nerve health, elevate symptoms of nerve damage such as tingling, numbness, or pain. In community pharmacy setting is very common. So when this happens, a lot of people will be, they feel very anxious because they worry about some other things will come, and then they will quickly come and look for a cure. So this is most likely due to the nerve damage. So you can tell them that it's okay, there are, it can be reversed, but you really have to see what is the severity, right? Then secondly is the energy metabolism. So there are seniors who are actually lack of vitamin B in the body. So they always, probably say that they don't have enough energy. So commonly in a government setting also, they are very common that they given complex and all that. They'll tell you the yellow tablets and so on. So for energy metabolism, one vitamin B complex is very important to convert your food into energy. So whatever food that you eat, it may not convert to energy unless you have enough complex in the body. Okay, so that's why you need to eat enough portions from your diet. Thirdly is neurological function. All right, maintaining the health of the nervous system may help to prevent neurological disorder related to deficiency. So this part, these 3 areas you can actually counsel your patients on. Okay. Okay, this part, dosage and administration. There are many manufacturers nowadays on the vitamin B complex. As a pharmacist, it's important that you study every one of them. Okay, and well, we can see that some may suggest that say, oh, maybe 1 tablet daily. Some may say 2 a day, 3 a day. So it's really have this deep dive into the individual vitamin B complex. Okay, you can weigh, how much you really recommend and what area, what symptoms they have and so on. And normally I would suggest to take the tablet before after meal to improve the absorption and reduce the risk of the gastro and intestinal discomfort. So basically, best to take after meals, for example, after breakfast or after lunch. And then they may actually, for me, I usually tell them that, if you take more vitamin B complex, your urine may be, a bit yellowy, this is okay, it's water soluble, you can just you stone off later. It's not to say that, wow, yellow urine, and then you're a bit worried, why is that so? Okay. So next, potential side effect. So that's a part, just now I keep mentioning about gastrointestinal side effect. Yes, this is very common. Nausea, diarrhea, stomach upset. Anything that swallow in must go out, must go through your stomach. So you just warn them, these are the common side effects, okay? And some people may not tolerate vitamin B complex well, so that's how they have symptoms such as rash, swelling, or even feeling dizzy, trouble, difficulty. That's when, wow, very serious allergic reaction happen. So if that's so, just ask them to stop it and go to an emergency department. Because the potential side effect we talk about with high doses, okay, just vitamin B6 deep dive, okay, can cause neuropathy. So ensure that the patients adhere to the recommended dosage to avoid this risk, right? Okay. Drug interaction, I think I already mentioned that there are a few medications that may cause interactions. The L-DOPA, pyridoxine, this one even more, pyridoxine antagonists such as the isoniazid, cycloserine, penicillamine, hydralazine, okay, where the vitamin B6 may be decreased, okay, and loop diuretics, those on furosemide for long term, the vitamin B1, okay, called thiamine may be reduced. And then if you take long-term acid lowering agent, it may reduce your vitamin B12. For example, omeprazole, all those pantoprazole and so on. So if you take just acid lowering, keep on popping acid lowering tablets, yeah, that's one thing that it will cause vitamin B12 deficiency. And for medical conditions wise, of course, people with CKD, chronic and all that, you should actually be very cautious. Okay, they may not um, absorb, the vitamin complex better now. And then or any history of allergy lah. Just ask every patient that come in, seeking for B complexes. So do you have any allergies? Sometimes they may tell you, I don't know, you see. So ask them to, maybe start slow, okay? Maybe just take one a day and see any reaction or not. If you have, it definitely have the reaction very fast, okay? Okay, this part on signs of deficiency and indications. So if you have a deficiency symptoms, okay, quite common, okay, for maybe for more seniors one, they don't eat well, okay, they feel that they don't like to eat more food now, so they will probably feel tired, okay, feel weak, anemic, or they have sometimes they have tingling sensation. When you have this, it's commonly causing deficit due to deficiency symptoms already. So if that happens, okay, I'll show you some case study, okay, interesting ones. You may suggest the B1, B6, and B12 to prevent the deficiency, especially individuals with conditions such as diabetes, chronic alcohol consumptions, and certain gastrointestinal disease. Okay, just now we talk about diabetes. It's a very common diabetes because the diabetes medication that can go in, right? Some people would love to drink their beer daily or even their red wines. Just watch out on that. Okay, they definitely have these decrease. They have these deficiency symptoms, and those people popping omeprazole all the time or having certain gastric problem and all that. That is the area that you can go in. Okay, and to discuss a bit more. Okay, consultation and monitoring. So this is a part where we encourage patients to have regular checkup with their healthcare professional to monitor their vitamin levels and overall health. So I think there are people who actually check the complex also, okay, from the blood and so on. So they just want to be very, very extra careful. And even though if you have deficiency, you probably feel a bit weak, anemic and so on. But watch out, people who are weak and all that. Ask about a bit, just basic diet. If they are taking enough, are they vegetarians? Are they taking less meat now or so on? Some people may not have any appetite to eat more. Okay, so that's how it's important for pharmacists, especially community pharmacists, to actually ask them, how's the health status now? And if they are taking the complex already, do ask them to report, okay, any unusual or persistent symptoms like gastrointestinal effect and all that, or the peripheral neuropathy never go away and so on. So pharmacist's role is actually very important, okay, because it will provide comprehensive counseling to ensure that they use the vitamin B1, B6, and B12 safely and also effectively. And if you understand, okay, the benefits, okay, just have to tell them that if there's any side effects or any interaction, if they're taking any other medication, that's how the medication review come in, and you really have to review it properly and ask them, what are the supplements, even TCM and so on, that just lump all in and review it for them properly. Then that's how you can find a blind spot for them and help them, okay, to careful all those blind spots and loopholes that you may not be aware. Okay. So I would like to go on to this part. The third part is actually on when do you refer to a doctor? A lot of times, pharmacists may say that, uh, I really do not know when to refer to a doctor. Actually, as a community pharmacist, you feel that, something that really need further checkup and all that, it's okay to always, call up your friendly doctor, or maybe certain specialists that may be helping, okay, this patient. Um, just do a referral. Don't lump it to yourself and trying to solve the problem, but you can't. Okay, so these few categories of people, you just have to be really careful. For example, okay, if the patient is already with a chronic condition such as kidney disease, liver disease, or even heart disease, you know that they are due to old age. They bring you the report, they tell you, oh, it's very complication a lot and all that. Just be very careful, okay, and just refer, right? And medical interactions, polypharmacy is very common. Some patient may go to hospital A, hospital B, pharmacist A, pharmacist B, and this will recommend that. So many opinions. Okay, they may come in with bags full of medication and don't know what to do with that. So this is where the medical interaction will happen, and polypharmacy happen. So as a community pharmacist, you just have to review them and find out what is the root cause or blind spot for them. Okay. Of course, the third one is actually on side effects. So if the patient taken one tablet of the B complex and suddenly tell you that you have rashes all over the body, yeah, this is quite common sometimes. Gastrointestinal issues, neurological symptoms, and all that. These are unusual ones. You just have to trigger yourself that, hey, this is unusual. I cannot treat it anymore. Please refer to a doctor. Okay. For pregnancy and breastfeeding, definitely, this is always very, very careful. You're not sure, always ask, go to the doctor, okay, because pregnancy, there are many complications sometimes, okay. Not sure, just refer. Okay, just now I talked about long-term use of vitamin B1, B6 in health. Okay, B6 you cannot use like really more than 4 days on high doses or long-term use. So sometimes may need some dose adjustment. Okay, so for serious cases, I suggest to also discuss with doctors. Okay, so that the patient get the quality of life at the end of the day. Nutrient deficiency symptoms. You feel that the patient maybe is a big eater, suddenly lost weight, ask about their BMI, ask about do they weigh themselves recently, if they have, weakness and also all suddenly lost weight, then they may have nutrient deficiency symptoms. And that's how you really have to find out, have they done any blood tests and then anything that you can help, then you can start referring already. Okay. Overdose concern, yeah, just now we talk about overdose a lot on vitamin B6. If in case of you suspect something suspicious, overdose is definitely there, and then you wanted to really, really help them. Okay, just calculate the dose for them and say that, hey, it's really definitely overdose, and I would like to refer you to a doctor. Okay, this is the final part of my talk. I would like to share some case study that I feel it's interesting, okay, may or may not happen to you, right? But it's quite common because we have seen people from all walks of life coming into your pharmacy sometimes as a community pharmacist, or even in a hospital setting, you probably, while interviewing or consulting, you probably can see, their lifestyle is different, their profession is different, and on and so on. So case number one, I would like to talk on Mr. A, okay? Mr. A is a 60-year-old man, 59 kg, he's a retiree, and he doesn't like to do exercise. So being a retiree, definitely they say, I don't have mood to do anything. Okay, so complaints of lack of energy and weakness. And he said that I only eat 2 meals a day because I don't have appetite. I don't like to do anything. So, and he has a chronic comorbidity such as hypertension, diabetes, and dyslipidemia. Oh, very common, huh? And his medication lists from doctor are amlodipine, 5 mg, metformin, 500 mg, simvastatin, 10 mg, and aspirin, 100 mg. And so what can a community pharmacist suggest? I think this is very common for a person with just starting to have all these issues at a retiree age, and they'll tell you that I don't eat much, that is quite common, okay, to suggest one on this. complex because you have to identify these comorbidities, hypertension, diabetes, dyslipidemia, and also the metformin treatment. All right, metformin treatment, a person who is taking metformin already, it will interfere with the vitamin B complex absorption. So that's how mainly a B complex in the diet or only as a supplement. Okay, and of course, the age is higher, it's already a senior category, 60 years old and above. Not eating much. So these are the key points that you would like to pay attention to, and that's how you have to see, if the B complex is needed. For this case, if the patient is not taking any other supplements, okay, to assess first. Okay, if it is definitely not, yeah, why not? You can suggest some B complex to them so that they can see a difference in their energy. Okay. All right. Second case, 4 cases. Mr. B is a 48-year-old, 80 kg overweight, drink a can of beer daily as he has insomnia. And then he smokes 1 packet of cigarette a daily. Okay. Then he does not exercise and feels tired all the time. And his mother is a diabetic patient and his father is a stroke patient. So what I can accommodate pharmacist. So you see from this case, you can already identify a few things, a few keywords. Okay. So overweight, drink a can of beer daily, cannot sleep, the alcohol, okay, and also a smoker, no exercise, and history, okay, parents, okay, diabetes and stroke. So he is not taking any other supplements at all, okay. So that's how these are the keywords: smoking, alcohol and consumption, obesity, low physical activity, and genetic factors for diabetes and peripheral neuropathy in the family. So that's how the complex will be needed. So I suggest that, okay. Case number 3, Madam C is a 30-year-old on vegetarian diet for past 2 years. And she suffers from pins and needles on the leg, and she rarely exercises and feels very weak, and her parents are diabetics. So what can a community pharmacist do? So again, vegetarian diet, very common, okay, they do not have enough, they may be animal, right? Some people, some patients are used to become not a vegetarian, okay, some are like vegetarian for since born, okay, but this kind is like 30 years old, suddenly become a vegetarian. Sometimes, certain belief, religious belief and now they switch. When they switch, they do not know, the impact of switching from a meat diet, or we call it omnivorous diet, to become a vegetarian diet. Imagine if you are religious enough, some people actually do vegetarian daily, but they do not know how to compensate. They do not know how to improve. They don't even think of B12, even B complex at all. They feel that taking vegetables is good already. They don't have to take anything, because a lot of people have this misconception where meat will cause heart attack or stroke. So that's why they refuse to take meat. They go on veggie diet or even fish diet. It's very common in a community pharmacy setting. So that's why when they switch, they suddenly, feel pain, feel numbness, and also on. So it's quite common, and they start to become anxious and walk in to see you as a community pharmacist. And that's how, there's a part you can play a role. Okay, you can just suggest a B complex to them for a start, right? There may be other things in happening, but you're just looking at this a case by itself. I would just say that why don't you can just start if it already assess the whole family history and so on, not taking any other supplements and so on, or even TCM and so on. Okay, so this is a part where community pharmacists can play a role. Okay. Okay, finally, this is a bit more complicated. Okay, this case is actually Mr. T, 70-year-old, stay in a nursing home, smoker was an ex-smoker, okay, for 30 years now, no longer smoking. And he suffered from stroke a month ago and now suffered from pins and needles on his feet. And these are the medications. So you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10. Okay, you can see that the kidney are not working well, diabetic, already taking like pantoprazole, when I had medications called like this lipidemia, and blood thinners, and even furosemide and so on. So I suggest that, of course, by looking at this, yes, why not, of course, careful on the diuretics and also on. So for a start, you just can just ask him, if he's taking any other supplements and so on. So again, okay, he is a CKD, he's already taking around and all that. Well, for this case, if you are the community pharmacist and this, let's say you have a prescription for that, and he has some symptoms, well, I suggest that you may talk to the doctor, okay, or if the doctor is suggesting any complex exam, okay, or if there's any other underlying diseases, okay, before you recommend, okay. So for a start, low dose B complex maybe for a start, okay, to see whether it's helping. But for more chronic, why not you just have to discuss it with the doctor, because yeah, I mean, these are the from one doctor lah, huh? He doesn't go to any other healthcare facility already from one doctor or that. So there are cases where when the stroke patient has this issue, they may take a certain B complex on the short term and let you repair and see more benefits in the recovery stage and the quality of care and so on. So that's where you can add on this advice, but just maybe you can do a review and also sit with the doctor and see how the improvement is. So that's all for my presentation today. Okay, do you have any questions?
Yeah, we will do the Q&A question later.
Yeah.
Yeah,
later.
thank you, Gina, for
Okay, thank
sharing
you.
everything, especially on the pharmacy counseling. With
Yeah.
your case studies, right, I believe we all learned something on the important roles of vitamin B. Okay, so after understanding the vitamin B, following the next speaker, Dr. Nevin will bring us through the clinical papers, okay, on the evidence use of vitamin B in neuropathy. It is my privilege to introduce Dr. Naveen Kumar Loganathan, a distinguished senior clinical pharmacist at Putrajaya Hospital in Malaysia. Dr. Naveen is currently heads the specialist clinic pharmacies and medication therapy adherent clinics and tech services at the Endocrine Institute. With over 16 years of experience in diabetes care, he is also the chairman of the Diabetes Clinical Pharmacy Subcommittee at the Ministry of Health. Dr. Naveen holds a Bachelor of Pharmacy and a Master of Clinical Pharmacy from the National University of Malaysia and a PhD in Pharmacogenomics of Anti-Diabetic Therapy from UM. He has been recognized globally, including being one of the 20 recipients of the Next Generation Scientist Award 2016 by University of Basel, Switzerland. Let's welcome Dr. Naveen Kumar Loganathan on the evidence to practice for vitamin B combination therapy. The floor is yours, Dr. Naveen.
Yes. Thank you. Thank you very much, Mr. Wenkit. So I'm actually happy to speak today to all the pharmacists from Malaysia and Singapore. And very nicely, the first speaker has already set the scene about diabetic peripheral neuropathy, which is one of the important things that's often overlooked. I think from my experience, I would say this area is often not really optimized in terms of treatment. A lot of things needed to be done for this peripheral neuropathy. And then the second speaker, Gina, also spoke a lot about vitamin B6 and also how pharmacists can actually refer to the doctor. So today, what I will be sharing will be, about the evidence and how we can actually utilize the evidence in our practice about vitamin B combination therapy in peripheral neuropathy, right? So I will start off by just speaking to you about the treatment of peripheral neuropathy and diabetic peripheral neuropathy with vitamin B. Yeah. So again, just to recap what I think has been said earlier by the first two speakers. So peripheral neuropathy is a chronic condition. Okay, it's a chronic condition. Of course, you also have the acute form of peripheral neuropathy, but generally, if it happens in a diabetic patient, which is most often the case, right, of peripheral neuropathy that you get, is mostly the diabetic patients. Okay, so this is actually a chronic disease that slowly progresses over time. Okay, over the course of many years. All right, so you can have a diabetic patient who is a long-standing diabetes, 20, 30 years. So this peripheral neuropathy has already started much earlier, probably at diagnosis itself, right? And it requires long-term treatment. Whereas there are some times that you can get acute instances of peripheral neuropathy, which actually does not really need a long-term treatment. So it's just probably due to drug-induced, like, the earlier speakers have also showed you about drug-induced neuropathy, which can just go off, in a short period, and probably does not need longer treatment. Yeah. The early diagnosis and timely treatment will prevent peripheral neuropathy progression and symptoms. So what we worry about, this peripheral neuropathy, if even sharing my experience, because I see a lot of diabetes patients, it's not that totally you can eliminate the possibility that of them having this peripheral neuropathy, because it is one of the complications of diabetes and poor control of diabetes, right? Knowing that only in Malaysia, if you take, for example, only 1/3 of our 30% of our diabetes patients have their sugars controlled. So a large number of them do not have their glucose under control, and definitely some point or later they will develop this neuropathy, peripheral neuropathy. But what we do not want is the symptoms, the pain. That's the one that, later I'll also be sharing with you, will disturb their life. And also, previously we also heard that actually that this is also associated with a lot of depression. It's called diabetes distress, and it's very disturbing for the patient, right? So as again, I mentioned just now, a lot of emphasis we give to macrovascular complications like heart attack and also kidney failure and so on. But I think this is one area that we really need to really emphasize, because if, let's say, peripheral neuropathy progresses and becomes worse, then the sensation will be lost and the patient will start to, have a risk of amputation, because they start to have the wounds, like the first speaker, when Kit mentioned just now, the wounds not healed, then they will have a risk of amputation of the toes and probably the leg, and this is really, really associated with high mortality. If you look here, the early diagnosis is what that we want, but often not really optimized. In real practice, people, most practitioners will focus on controlling blood glucose. All right. But if the sugars are not optimized, this peripheral neuropathy will progress. Okay, so just because diabetic peripheral neuropathy is multifactorial, the treatment should be actually as early as possible. There's no such thing. Even if you ask me, I will definitely advocate patients to be starting on this vitamin B supplements very early, even when they have started being diagnosed as diabetes, because don't have wait until they have symptoms, right? Because we know that this is definitely going to happen with poor glucose control. All right. So also, if let's say you're not already on, the patient's not already on, once they already have symptoms, definitely there's no waiting. You have to start. Yeah, so that they can relieve the symptoms and also manage the complications. And as I think we have also heard earlier, in the first lecture, there is actually a point of no return. You want to intervene early so that you can actually reverse and restore and regenerate the nerves before the hope is lost. Okay, you cannot go to the very late stage that you cannot do anything, right? So glucose control actually will slow the progression of diabetes. That's what I mentioned. We are always, the way we manage diabetes is actually we want to bring down the glucose to the normal range as long as possible. So the patient is essentially in a normal range, so that you do not want all the vessels to be disturbed, all the inflammations that happen at the vessel or the nerves itself, to be damaged. Okay, so you want to control, but it's not always possible. Even if you have a good glucose control, this does not really stop the peripheral neuropathy, and also the symptoms. Okay, so usually there are many factors for this, because one of it, you'll be very surprised that actually, what this thing, I feel actually I really pity the diabetes patients, because if you look at the management of diabetes, most common, I think in more than 90% of the patients, the first pharmacotherapy agent that's initiated is actually metformin. All right, metformin is the first agent that's initiated in diabetes treatment. And after that, if let's say the sugars are not controlled, you add on with other agents like probably sulfonylureas or DPP-4 and all that. And actually the medications are added on with insulin, but most of the time the metformin is not stopped because it's relatively safe and it's good for insulin resistance. So because the metformin is there for a long time, it also causes vitamin B12 deficiency, which I'll show you later. All right. So what I wanted to highlight here is actually, the symptomatic treatment does not really target the underlying nerve damage. So there is a nerve damage. Often the diabetes patients actually inside them, they have a lot of complications that is not seen from outside. We cannot see with the naked eye. Yes, they will start to have symptoms like pricking and tingling and all that, right? But what you can do, if a common person even walks into the pharmacy, let's say to Gina, and says that he has pain and all that, or any community pharmacist, because if let's say you do not take a detailed history, not knowing that they have diabetes and all that, most often people will just want to relieve the pain. All right, so it's very common to start off with PCM and so on. But then, the symptomatic relief itself is nothing. It's just temporarily just like numbing the situation at that time. But it does not actually stop the disease, the diabetic peripheral neuropathy inside, right? So we have to target the pathogenic mechanisms, okay, to reduce the dysfunction. Okay, so some pharmacologic and alternative treatments have been designed to modify diabetic peripheral neuropathy and favorably influence the underlying pathology, right? They aim, okay, it's this one. I'm not going to read everything, but if you see AGE, okay, or ROS, these are all inflammatory markers. So diabetes actually is really dangerous because it can activate or release this inflammatory markers that go and damage your blood vessel, that cause heart disease, that cause kidney disease, that can damage your nerve cells, okay, that can cause diabetic neuropathy. All right. So there are also pharmacological treatments, for example, like ACE inhibitors that the patient's on and all that, that actually also causes this. And actually, I mean, sorry, that these ACE inhibitors that actually we can target this, and also there's some alternative treatments that we can target the neuropathy, which is actually by using the B complex or vitamin B vitamins, particularly the ones that contain B1, B6, and B12. And now we also have things like alpha lipoic acids. All these are actually targeting inflammation. If you see the ALA, L-carnitine, and so on, right? Okay. Now, we are interested as pharmacists, right? What are medications that actually cause vitamin B deficiency? So you can see here, if you just divide the table is divided to B1, B6, and B12. So there are some drugs that, particularly cause reduction in like B6, like the anticonvulsants, like, topiramate, phenobarbital, or some anti-TB drugs, carbidopa, and so on. There are also loop diuretics like furosemide reduce B1, and as I mentioned just now, metformin, ranitidine, cimetidine, and PPIs also actually is quite commonly taken by diabetic patients as well, also can cause B12 deficiency. So this one, if you look at the American Diabetes Association, has already spelled out, this is the 2022 guidelines have already spelled out long-term use of metformin may be associated with, vitamin B12 deficiency. This one the practitioners already knew much earlier. But I would say that I think FDA or ADA and the authorities actually just reported recently about this, that actually this is something that we need to consider. If you look here, when the metformin dose increases, you start off with 500 milligram, then you go to 500 OD, you go to 500 BD, and you go to 1 gram or 1 gram BD. As the dose increases, the vitamin B12 decreases. You can see from this study. Also, you can see, peripheral neuropathy is associated with increased risk of limb amputation. This is what we really cannot take the peripheral neuropathy very lightly, because this is what really will happen to them at the end. Because the legs and the limbs actually, they won't have sensation. and they can just get a small wound that actually will take very long months. Sometimes I've seen a lot of my patients 8 months, 9 months go dressing every day just to heal a small wound, because the wound is not healing, and because of that they have high risk of having infection, gangrene, and also they can die of that because of sepsis, right? So different factors need to be considered in drug-induced vitamin B deficiency. We know already the drugs cause B deficiency, right? So symptoms can be different. Okay, so we really have to look at it differently, right? And especially in patients within the risk populations of vitamin B12 deficiency, like diabetics and elderly, you should be really monitoring the use of vitamin B12 carefully as well. And also there are also dose dependent effects that are observed in certain groups. And treatment duration, we're also going to look at it after this. How long do you need to treat? Can you stop? When do you stop, and all that is also very important. So how are vitamin B deficiency and peripheral neuropathy is connected? See, just now I was telling you, if a patient is a diabetic for 20 years or 30 years, and let's say within diagnosis, upon diagnosis, already started with metformin, the patient is on metformin for 20 or 30 years, and the patient's vitamin B12 declines, and the peripheral neuropathy also starts. So one side is the disease itself, the diabetic disease itself, because the glucose is high and causes the inflammation and damage to the nerve. Another thing is the B12 deficiency is caused by the drug. So do you see that the diabetes patient is actually at a very high disadvantage, because both the disease and the drug actually accelerate this process of B deficiency? All right, and you can see there's a deficiency in B1, B6, and B12. And so all these other things, if present, not only the drugs, like I mentioned just now, the toxins, and also can actually accelerate this process, right? So this is all. I'm not going to go very detailed, but guidance on the management of early stages of peripheral neuropathy is actually still unclear, but there are a lot of evidence. We try to present the evidence to you today, but medications are the basis of treatment recommendation for neuropathic pain, right? There's no such thing like things like maybe for obesity, you can say go and exercise and then come back for 6 months or 1 year, we see whether you need treatment with drugs and all that. But this one is actually medications really useful for neuropathic pain. Of course, the first line can be things like, you also can give like gabapentin or SNRIs and all that. And actually, there are also, these are all for symptoms. And when they already have symptoms, that means they have this burning pain, the tingling, burning sensation and all that. So there's no way, for doctors to, treat this. They have to start, actually these drugs to alleviate the symptoms. If not, the patient cannot sleep, or the patient cannot walk, or cannot actually, most of the time, my diabetic patients tell me that it's actually very bad at night. They cannot sleep because the whole leg actually is like burning. It's like on fire. They really have uneasiness. They cannot close their eyes. They cannot sleep. All right. So you use this first line, second line agent like tramadol, and also you have third line, fourth line. A lot of all these drugs actually are painkillers. Okay, they just numb the pain, but do they really treat the pathophysiology? Not really. Okay, and also you can see when you start using these drugs, so some of them are anticonvulsants. All right, like also like gabapentin and all that. Actually, also you need to reduce dose for renal impairment. It's actually very troublesome when you already at the late stage where you need drugs, okay? Because the drugs need to be monitored as well, all right? They have multiple side effects, okay? So there are unmet needs. Again, as I mentioned, from my experience also, I've seen that a lot needs to be done in terms of this nerve protection for diabetes patients, really not optimal. So, I'm not going to go very detailed on this, but you see the peripheral neuropathy, once it's even mild, you really need to treat it, because it's a missed opportunity. If you don't do it, what will happen to them? They'll progress to moderate, and then they'll start to show one or two symptoms will start to show pricking pain. Then when they're severe, then that's when they actually have the, burning sensation, loss of that sensation, which actually is very, dangerous and can cause amputation. So the management of peripheral neuropathy with this B1, B6, and B12, you actually for symptomatic treatment, you can actually focus. Of course, there's no way, as I mentioned, you have to use like pregabalin, gabapentin, and all that. You cannot just put them on vitamins and say that the pain will stop, because the vitamins actually is for nerve generation and protection, but you also need to tackle their pain. That's why when you have a symptomatic patient, we also will start both to alleviate the pain with this, for example, pregabalin, gabapentin, and also we put a nerve generator for you, which is the B1, B6, and B12, and also an ALA and so on, right? So, look at some evidence here. Why do we use neurotropic B vitamins? Neurotropic B vitamins means B1, B6, and B12, okay? So, you can see from this presentation, this evidence, that actually it provides significant total symptom score reduction. Okay, I'll show the total symptom score is actually all the symptoms like, pricking, pain, tingling, and all those things, right? The symptom score will actually reduce when you actually put the patients on these neurotropic B vitamins. Okay, so how do they do that? So the role of neurotropic B vitamins actually is actually very, very paramount, and we can actually say that it has two functions. One is to treat and also to protect. So when you treat, is actually when, as I mentioned, the first class group of patients who already have symptoms, they come with you telling it's burning, paining, and all that, they really cannot walk, they cannot sleep. Okay, these kind of patients, actually, you need to actually also give them symptomatic relief, and you start off this neurotropic B vitamins, which will improve their nerve function and promote the nerve regeneration. But one thing I will tell you, tell your patients to be patient, because it is not a magic wand. It will not work like within one day you start this neurotropic B vitamins, and then the next day you have the symptoms gone. No, because it will take some time to build up. We'll talk about the dosing later, maintenance, and after some time, I would say safely about 2 months or 3 months, you really can see that actually the pain actually reduces. Okay, we'll go to the evidence later. That's where actually it protects. Also, like, when you want to go for protection, the second one, you can even start it much earlier, even for patients who are diabetic, because it will happen to them. All right, so you can actually start much earlier itself, right? So why is long-term treatment with B vitamin B vitamin deficiency is mostly necessary? It's because it's actually chronic conditions for diabetes patients. It's not a temporary situation. It's a chronic condition, and so if you actually do not continue, that's why they need to be like on a maintenance that forever, to actually prevent the pains from starting, or because once they've passed the point of no return, that it's very hard to actually come back, right? So I'm not going to go very detailed on this, but the ongoing treatment of nerve-related symptoms can prevent relapse of symptoms. Just to show you that actually you put the patients on maintenance, actually you can prevent the symptoms. The symptoms are the one that's actually disturbing them, right? They cannot go to work, they cannot sleep, and so on, right? So the role of neurotropic B vitamins in nerve generation and protection, as we want to explore further, is, you see, you have B1, B6, B12. What are they? The B1 is called as an activator because it provides the energy for nerve cells. Everything is centered on nerve cells here, because the nerve cell is, the main source of the pain. You see, just now the first speaker has explained about peripheral neuropathy, the myelin sheath, and all that. It's very important. So this one actually provides the energy. The B6 actually is the transmitter. It keys in the synthesis of neurotransmitters, and the B12 actually is the regenerator. It promotes nerve regeneration and myelin synthesis. Myelin is also very important. So in other words, when I tell patients, if let's say your myelin sheath is like your sweater or your jacket, you remove your jacket, you start feeling cold. So it's like that. When the myelin sheath is exposed, it's actually taken off, then you start to feel the pain because your nerve cell is exposed, right? So, the neurotropic B vitamins have important roles. So, as again, this is just re-emphasizing what I mentioned just now. I'm not going to go very detailed on that. In view of time, we'll speak on some more important things. The nerve restoring effect is also very dose dependent. Okay, so you see, compared to a cohort, control cohort, yeah, you can see here those were treated, right, with low dose vitamin B and medium dose and high dose. Actually, you can see those were treated with a higher dose actually have a better response. This is very, very important, okay, because sometimes you actually do not really adjust, or maybe the pharmacist or the doctors just put the patient on the same dose and never look at it, and then just continue same the regimen. Patients on 10 years, 20 years diabetic, then actually the peripheral neuropathy will progress just now, right, from mild, moderate to severe. And when you never optimize the vitamin B's, actually it's really going to be very, very damaging for the patient. Okay, so we'll just look at this Nenoin study, management of peripheral neuropathy with B1, B6, and B12. Okay, so the purpose of this study is to evaluate the efficacy and safety of fixed dose combination of neurotropic B vitamins in the treatment of peripheral neuropathy. Just look at the study objectives. That's the main one, but how they measure the patient's efficacy is actually through the clinical symptoms of peripheral neuropathy by using the total symptom score, TSS, from baseline to after 14 days and up to 3 months of treatment, right? And they also looked at quality of life and other symptoms, right? So just to give you a snapshot, what they did is actually a prospective study, okay, observational, and then they used a B1 of 100 mg, B6 of 100 mg, B12 of 5 mg, and then patient as they have given the patient to take it as once a day after meals. Okay, and they monitor in the intervals that I mentioned just now. They had about 411 patients. Yeah. So if you look here, the parameters that I mentioned is actually total symptom score and total symptom score by neuropathy symptom, and the secondary parameters were actually VAS by neuropathy symptoms, quality of life, and also safety. So coming to the results, okay, you can see after using this neurotropic B vitamins, okay, there is actually the patients actually relieved of neuropathy symptoms significantly with progressive improvements in total symptom score. You can see the decline from visit 1 to visit 5, all right, and even statistical significant reduction even after 14 days of putting the patient on this B1, B6, and B12. You can also see here all the neuropathy symptoms observed in the study with progressive improvements. So there are 4 types of symptoms there: stabbing pain, burning pain, and also you can see numbness, and all that actually have even significantly actually declined, and also especially even as early as 14 days. Here also you can see actually all the symptoms have been treated effectively, and the symptom relief actually, or the reduction in total symptom score actually happened in 63%, which is clinically significant and of high relevance to the patients, right? And you can see here all the patients actually experience significant relief on neuropathy symptoms independent of the cause of neuropathy. So whether this one is, it's in a broader concept, not necessarily diabetic, but those who actually had neuropathy due to carpal tunnel syndrome or idiopathic or other reasons also actually saw improvements. Yeah, so it's not just for diabetic neuropathy itself. So here you can see the patients were relieved of all observed neuropathy symptoms, and all the symptoms I mentioned just now: the pain, the burning, the paresthesia, the tingling. These are all the very, very symptoms that interfere with their daily lives. Okay, again, as early as 14 days itself, you can already see the symptomatic improvement. All right, and here again, just to show you in terms of visits. Yeah, so at visit 2, visit 3, visit 4, visit 5. So in visit 5, almost 70 to 80%, or in paresthesia improved in about 90% of patients. Yeah, so actually this is actually very remarkable, because just to show you that, as I mentioned just now, when you actually maintain the patient on these neurotropic B vitamins, you can actually restore the function. That is actually the key thing that we want to say here. So management of peripheral neuropathy with this neurotropic B vitamins also actually explored the quality of life. As I mentioned, right, so being a diabetic patient already has disadvantage because they have to take multiple pills. We pharmacists know that, compliance is an issue. They have to take 3 times or 4 times a day medications, and also have to monitor the sugars. So it's already a very restricted life, for them. And if they have this kind of neuropathy that's interfering with their lifestyle, it's also going to cause a decline in their quality of life. So in this study, what you can see here, after being put on this neurotropic B vitamins, there's actually improvement in quality of life in both the physical and mental component. So usually you see quality of life, they have this 4 components. So you can see the physical component and the mental component. Physical means they actually can work or they feel active. Okay, I want to go out. I want to actually go to the mall. I want to watch movie. They don't feel like sitting in the house, right? And also the mental component, they feel more alert. Maybe they can do more work. They can engage with people and so on, right? So again, here you can see both the physical and mental functioning improve continuously due to the treatment of B vitamins. Up until visit 5, you can see consistently the quality of life scores actually kept increasing and their mental function actually increased. So again, you can see a disease, a condition, peripheral neuropathy, that's very debilitating, very, damaging to the patient, but actually it can actually improve their well-being, the general well-being, of the diabetic patient, So again, this one is just to show you the quality of life improvement at all the specific parameters like physical functioning, physical role, bodily pain, social functioning, and all that. But the message is actually the quality of life improved. Yeah. So here also you can see the quality of life improvements also. So just like earlier we talked about the symptoms or total symptom score. Similarly, the quality of life also, regardless of whether you are a diabetic or your neuropathy is due to carpal tunnel syndrome or idiopathic, actually the quality of life actually improved, right? So what this study can actually say, before we go to that, you can look at the safety itself, not really something that we need to really worry about. From all the 400 patients, only 14 patients actually experienced the adverse effects. Okay, 1 dyspepsia, 1 nausea, and 1 diabetic foot. It's all very minimal and actually definitely things that we can re-manage. Okay, so conclusion from this study, that Neon study, is actually there is actually, I mean, if I want to summarize, you can see total symptom improvements, symptom score reductions, and also you can see quality of life improvements, right, in the patients. Okay, those are real, patient studies, right? 400 over patients here. You also can complement this with in vitro studies that they do in the lab. Okay, you'll be very interested. How does actually this neurotropic B vitamins improve all these symptoms? Is it a magic? My patient is suffering, burning, cannot sleep, leg, painful, pricking, cannot walk. But, in 3 months, in 5 months, I can see that they are symptom free. How does this happen? Is it magic? So you want to understand that in lab, so in vitro studies, you can see here. So there's this study 1 that the objective is actually to look at the viability and functionality of healthy nerves in vitro, and also look at the regeneration ability in a damaged nerves. Okay, 1 healthy and 1 damaged. So here you can see, so in this study, it's a busy slide, but I just want to show you, they just wanted to investigate the mechanism of action of how the B1, B6, and B12 support the nerve health in primary cultures. They use a cell culture, right? So you can see that the neurite length, the length of the neurite actually increase continuously as soon as you start 6 days with vitamin B. You can see in the culture cells, actually the neurite length increased, all right? And also you can see that in the cultures that actually did not have the B1, B6, and B12, the neurite length actually decreased. So this is also to show that actually there's an impact when you put a B1, B6, B12, you can actually have preserved nerve cells, right? Here you also look at this neurotropic B vitamins, the effect on cell body clusters. Just to summarize this busy slide, actually the decrease in neurite length may be linked to a cell death response. Okay, because just now I mentioned that actually when you put the B1, B6, and B12, the neurite length increase, so there is less cell death. Okay, so when the neurite length actually decreases, especially when no neurotropic B vitamin is given, then actually the cell death happens. When more and more of your nerve cells die, then all the symptoms will start to appear, right? So again, just to tell you here that actually the B1, B6, B12 actually improves the neuronal health and nerve network formation. So you can see there, On the left-hand side of the picture, you can see there's some kind of networks, right? It's actually you can see like wires there, networks, and the right-hand side, actually, you don't really see anything. It's just look like a space, like dark, correct? So the left-hand side is actually supplemented with B1, B6, B12. The right-hand side that you don't see any network is actually the cultures that's actually not given the B1, B6, and B12. So again, that is actually healthy cells. So what about damaged cells? Okay, they also did this study in the lab to look at actually how they support the nerve recovery. Okay, so you can see that this one, I just want to show you in view of time. So you have these three pictures here. You can see the left one, the most left is actually the cell with no damage, no peripheral neuropathy, no damage. And then the second one is actually you don't supplement this cell with B1, B6, and B12. And then the right-hand side, actually, you have a damaged nerve cell that you supplement with B1, B6, B12, right? So the second one you see, which is not supplemented, the damaged nerve cell that's not supplemented, actually, you don't see much network formation. Okay, no, not much nerve cells. The green ones are actually nerve cells. But you can see that most right, actually, you can see a lot of nerve cells, the green ones, are grown. Okay, because of this B1, B6, B12 supplementation. So you can see that B1, B6, B12 have a strong effect of nerve regeneration capacity in damaged nerve cells. So now, what do we understand from here is actually, there is some hope. I'm quite happy to tell you there's some hope when patients come to you telling, oh, okay, I cannot sleep. I'm having, my whole feet is burning and all that. Is there any hope to them? Yes, there is hope. As long as actually they have not gone to the point of no return, they come somewhere in the middle of the disease, you can actually supplement with this neurotropic B vitamin and then regenerate back their nerve. Okay, here again, you can see before and after the nerve damage. When you supplement, you can see that actually the neurite length, the length of the neurite actually increases. So in summary, this study, the in vitro study, have shown that the combination of B1, B6, B12 has significantly improved the neurite outgrowth and also has a more than twofold higher neurite regeneration capacity. There is a 87% recovery of the damaged nerve cells when you supplement with neurotropic B vitamins. Okay, so I'm going to the dose. As pharmacists, we need to know how much to give, right? When they come to you, how much do you want to give this patient this B12, right? So we talk about a little bit about loading dose and maintenance dose, but before that, you can see this is actually a consensus statement, all right? Regional multidisciplinary consensus expert panel that contains 4 endocrinologists, 3 neurologists, and also 1 pharmacologist. So the aim of this consensus is to provide a practical guidance to primary care physicians on integrated approach to managing peripheral neuropathy with neurotropic B vitamins, right? So of course, based on the experiences and expert panel views and opinions, I'm not going to go here. So let's just go to this definition of the loading dose and maintenance dose. So you all know that, I'm very sure that as pharmacists, we have done therapeutic drug monitoring. In our syllabus, we have talked about loading dose and maintenance dose. So for sometimes you want to kickstart the effect, you need to have a loading dose, which is an initial high dose that's necessary to achieve the minimum effective concentration. All right, then after that, you supplement with the maintenance dose. So, of course, I'm not going to go this just to show you that loading dose has been used in other diseases and other drugs like digoxin, procainamide, and so on, right? But what we are interested here is this. How much loading dose do you want to give, all right? How long do you want to give the loading dose? So you give loading dose, okay, and you follow up with a maintenance dose because the loading dose is shown that can benefit the patients because they're having that, especially those who are having symptoms, all right? Maybe those who are not having any symptoms or pain-free, you can start off with a maintenance dose. So you see this paper, older people with mild vitamin B12 deficiency showed dose-dependent increase in B12 absorption. Yeah, so dose-dependent. So you slowly need to gradually increase the dose of that vitamin B12 and see what you call the benefit, right? So again, here you can see that, in terms of dose, those you supplement the higher dose and those you supplement a lower dose, also there is a difference. Those on a higher dose of this vitamin B12, B1 and B6, okay, you can see that actually they experience a greater symptom relief. So this is what I said actually. Sometimes in practice, like I know practicing in diabetes MTech clinic, I can see the patients They're put on a very low dose, okay? And then after that, nobody up titrate their dose or tell them that can you double your dose? You're already 10 years and all that. So because the disease is progressing, but as soon as you double the dose and triple the dose, you can see that actually the symptoms start to reduce. Okay, so here you can see patients who diabetic peripheral neuropathy who had a high initial dose of vitamin B vitamins actually have better outcomes. So that means you give a slightly higher dose in the beginning, then these people actually will benefit better than you just maintain a low dose, right? Okay, so is there any role that if like that, your brain will be thinking, I also have all these vitamin Bs, like B12 and all that in a injectable form. Shall I just give them injection every day? Okay, so what does the evidence say here? So injectable neurotropic B vitamins are useful to ensure rapid restoration of B12 levels, right? You want to rapidly restore because maybe you want to shorten the period the patient is suffering. Okay, so from here you can see that the British Society for Hematology recommends injections every other day for up to 2 to 3 weeks until no further symptom improvement. Yeah, you can use up to 3 weeks. And for oral tablets of B12, you can use in patients with asymptomatic or mild disease without absorption concerns, right? So generally, you can start giving injection, B1, B6, and B12 to patients with peripheral neuropathy presenting with symptoms. Just remember, if they have symptoms or if they have GI disorders like bloating, and all this GI upset gastroparesis, you can actually use that, right? And also, in terms of the maintenance dose, you all know maintenance dose is the dose that's required to maintain the minimum concentration. So this is also underlying the fact that the compliance is very important. Not just take for 1 week and then stop for 1 month, 2 months and expecting magic to happen. No. That's why I tell my patient, this is a vitamin, this is supplementation. It is not like your painkiller or like your, tramadol or whatever will just relieve your pain for a while, you can stop. No, this one you need to continuously take, right? So you can see here, once you start, the loading dose is to treat that, that symptoms. And the maintenance dose is to protect so that you don't actually have the pain later. All right, so I'll just quickly go to what the guidelines say, yeah? But before that, patients experiencing peripheral neuropathy symptom relief could be transitioned to a maintenance dose to a lower dose. That's also I want to mention to you. There is a possibility that they can be going down to a lower maintenance dose, not always on the higher dose, if actually they show improvement. All right, that's also possible, right? So other considerations for dose adjustments is actually, one of the key criteria that's very important, from adjusting from a loading dose, high dose to maintenance dose is actually symptom relief. This is actually something that, very easy for us to do because in the clinic setting or whatever, even in the doctor's room also, we really do not have anything to really like suddenly instantly measure their B12 level or B1, B6 levels, right? We can't instantly do it. It's not routinely done in care, not even in GP. So usually how they manage is just actually to ask the patient, how's your symptoms? Last time you say burning, so has it reduced? Can you sleep? Okay, so it's actually by the symptomatic reports, right? And so in general, if you look here, so from whatever I said just now and the evidence that I presented, so you can just see a simple algorithm here. How do we manage peripheral neuropathy with neurotropic B vitamins? Okay, so if you have a patient at high risk of developing peripheral neuropathy, and then you ask the question, are they symptomatic? Symptomatic means they have the tingling, the pricking sensation, the burning, all these symptoms that are disturbing to them. If they have that, yes, you start treatment with the loading dose, the high dose vitamin B6, B1, B6, and B12. All right. If they're not symptomatic, then you can use a prophylactic maintenance dose. Okay, a lower maintenance dose. Okay, even if those were treated with loading dose, you can see if the symptoms actually resolve, alleviated, you can actually go back to a lower maintenance dose. So just imagine symptoms you really need to treat with high dose, and then symptom-free you treat with the maintenance dose. Okay, so I think with that, I hope I've presented to you the evidence and for this neurotropic B vitamins and how they actually can elevate symptoms, quality of lives, and also I think probably they need to be continuously on it to prevent what we dread most is actually the amputation. From a hospital point of view, I see a lot of people having their leg amputated. So my advice would be just to put them on it for a long term so that actually they can get the benefit. With that, I actually pass to the Mr. Venkit. Yeah, thank you.
Thank you, Dr. Navin, for your really clear explanation on the complicated clinical studies with us. Because the diagram are very complicated, but you explained really clear for us. So I think it's loading dose of B vitamins is really something new for me as well. And there are many possibility that we can explore together with the treatment of B complex. Because some of them I think is unmet. They don't know they need them, but actually it will be very helpful, right?
Yes, yes.
So yeah, so together with Miss Gina, then now we are going to the Q&A session. So you all can feel free to just type at the Q&A, or if you have any specific question to ask any of the speaker, you can mention their name as well. So let me start by giving our first question of today. So there's a product called Adenovirus, right? So they contain 500 mg of vitamin B6 pyridoxine. So it is safe for customers to take it for a long period of time, because I think Dr. just mentioned that uh, usually B6 will give a high dose with the risk of neuropathy, right?
Okay.
Yeah. So what do you
Okay.
think, Miss Gina?
No, I just want to comment. Just now I did mention about B6. There's one brand that contains 200 mg. For B, the maximum dose. I mean, I'm talking about. Well, just now Dr. Navin talked about the loading and the maintaining. Instead of talking about in a retail setting, community pharmacy setting, normally one tablet easily around milligram. So just now I mentioned about maximum dose of 500 milligram to prevent the toxicity. So if a person has already got diabetes, maybe progression and all that, it's good to take at just now I did mention about up to 200 days, so that's why I say yes and no lah. Maybe a good loading dose to see the benefit effects. Then after that, at a lower dose and monitor for maybe 6 months. Then I would say that discuss with the doctor and all that to continue monitoring, because there are studies up to months. So really have to depend case by case. So that's why.
Yeah. Dr. Nami, how frequent you encounter to use a high loading dose, like for example, more than 500 mg of vitamin B6?
Yeah. So it's very clear actually. You have to ask the patients about the symptoms, do a little bit of history. So simple thing that it's actually if they're diabetic, then I would say that that it's going to be long-term problem. So and then when they already have at least 2 or 3 symptoms like burning, even pricking is probably the start. But if you see that it's already burning, and they say that they cannot sleep and all this kind of things, actually definitely you need to actually give them a loading dose, because if you give a maintenance dose like the lower dose, it'll take probably longer, a few months to build up. Okay, the levels of B1, B6, and B12 to build up, and after that only you can restore the nerve damage. But if you want to shorten the period that they're suffering from the pain, you will actually give loading dose for this type of patients. Only for those who are actually symptom free, they all very minimal symptoms like just 1 break, 2 breaks like that. They're starting, they just tell you to choke and like that, then you can actually give a low dose, right?
Yeah, I think still depends on the customer symptoms. For
Yes.
general population, I think we work the high dose, but for those like very dangerous for this neuropathy, then a loading dose or the higher dose might be preferred.
Yes.
Okay, so another question will be on, let's say a customer is taking a multivitamin complex. So maybe inside there B1 to everything inside. Then for anemia, then they take another like neurobion for peripheral neuropathy. Is it appropriate, or yeah, what's your stand on this? Yeah, Miss Gina?
Then have to see what brand of the multivitamin. Because if it's multivitamin, normally I can see all the B complex, and other than B1, B6 itself, there'll be a B. That there's a lot of B's. So if you want to take a specific brand of B1, B6 itself, I suppose that you can combine the total dose as a pharmacist, you can probably just do a bit of calculation, because one is like a maintenance, really, very low dose, for other nutrient deficiency. But the other one is more like a treatment for a specific condition, like a neuropathy and so peripheral neuropathy and so on. So and also one thing is, if it's partially complex, some they have other side effects. So I would say, case by case, I wouldn't suggest to go at one go lah, because
Yeah.
patient will probably feel, the energy converted too fast and so on. There are many so-called side effects on the common psychology.
Yeah, I think it's important for us to evaluate each of the ingredient
Yeah.
and look at the dose, like.
Yeah.
Okay.
Yeah.
So the next question, I think, direct to Dr. Naveen, because this is more on high dose vitamin B6. Because since you say just now you just don't prefer it in the long term, right? So, like, for example, like how long do you think is okay, but or like after customer taking 6 months, is okay already. Can reduce the dose, or what's your usual practice or the
Yeah.
evidence to support this?
Yeah, as I mentioned just now, even in the if you just can remember just the algorithm that I mentioned just now, yes, we can actually titrate down. We can adjust the dose further down, right? Not necessarily they need a loading dose for a long time. Is when you start off with the loading dose, a higher dose, is just to actually shorten the time for that B12 concentration to build up. Okay, so if you give a lower dose, as I mentioned, you'll take a longer time for the concentration to build up. So here you just shorten the time, so you have a higher chance of boosting the B1, B6, B12 levels, to reach the therapeutic level and to restore the nerves. So once, of course, you also have to ask the patient the symptoms. I generally, in my practice, usually I see second to third month already can see the reduction in pain and all the symptoms that they mentioned. You already like 2 to 3 months, but provided they must be compliant. They must be taking it every day,
Yeah.
just like how they take their metformin. It's not, oh, it's this supplement, I'll stop 1 week. No, you won't get, because it's actually to build up a concentration. So then once let's say in the third month you see that the symptoms already reduced, then you probably don't need that higher dose. You just supplement with a maintenance dose, a low dose, and then make sure that they're compliant every day. Then you can actually make the patients symptom free.
Yeah. So after the patient symptom free, right? Do you still ask them to continue for a lowest dose possible?
No. So of course people either, this is very common, everybody, even people come and ask me about cholesterol, doctor, my cholesterol, control already, can I off the statin? It's a very common thing, right? But actually I
Yeah.
tell them, you reach this level is because of you're on that medication. If I take off that medication, you won't see the effect. So there's no such thing that you can go down further or you can just take it off. It probably just like a companion with you for the rest of your life. I would just recommend them, just don't stop, because you do not know
Yeah.
when the loss of sensation can happen, the wound and all that will happen. So it's safer for them to be on it for a long time. Just use the maintenance dose throughout, especially for diabetic lah. I'm telling you, diabetic neuropathy.
I think some of the customer they feedback that they're actually getting more hungry after taking vitamin B complex because their appetite also increase. So
Is
what
that
is
is that
mhm.
actually a placebo effect, or I did not know whether we have data to say, but generally I know some of our common people, they associate vitamins as being hungry. Yes, we do hear that. I'm very sure your community pharmacists also hear that, right? So so your question was what? What
Like
was it
what
you
what
want to
can be
say?
what can be done to reduce this issue, like because they are afraid of weight gain.
Mm.
Is there anything that we can suggest or to
Mm.
modify the vitamin D?
Mm. Not really. I actually do not know. I mean, because multivitamin, yes, probably, but this is just B1, B6, B12.
Mm-hmm.
I do not know. Maybe Gina, with from practice, you have experienced what kind of patients, but generally, it's not to say that when you actually take this B1, B6, B12, your appetite will increase. There's no such thing. But I think generally, probably they have more appetite, I would say. Right? It's not just it makes them uh hungry and eat a lot. It's just that I think they have more appetite. I don't know, maybe Gina can comment on this.
Um, yeah, a lot of people will say that I get hungry faster and get fat. Then to me, I feel that I have to weigh the benefits against the risks. So if the case is serious, like diabetes, neuropathy and all that, then they have more seriously suggest, the loading dose, especially for maybe for stroke patient or really serious diabetes, insulin and all that. They have the burning sensation. It's more critical. So I feel that this kind of patient, maybe senior age and all that, sometimes compliance is always an issue. So to me, there's no so-called okay already. That's like more serious case. If you're talking about community pharmacy setting, those like not so serious one, maybe they have a bit of pre-diabetic symptoms, start to feel a bit of numbing, pins and needle, then they're very worried. So maybe, at a community pharmacy setting in a tablet form for a short period of time, maybe 2, 3 months. Some will say that I don't want to take for even 3 months, Then after that they feel okay, then their diabetes under control, then maybe they will stop it. Very common because compliance is always a problem. So
Mm,
if they stop it, then they say, hey, I'm okay, maybe placebo effect. And then they will let go. They're very common. They will take and let go, take and let go,
Mm.
because maybe cost is an issue, compliance
mm,
is an issue, and so on. So for those serious, maybe bedridden one, they have no choice, maybe injection and med. You just want to relieve the symptom, improve quality of life, right? So to me, I would look at
Right.
the category of patients where they are now, yeah,
mm.
to decide.
Yeah. Thank you, Gina. So the next question will be, let's say the customer is not diabetic, maybe just have a high blood pressure. So is it vitamin B can help for the neuropathic issue as good as those with diabetics or not? Dr. Naveen?
Actually, yes, you see, I take your question as general neuropathy. Of course, the one that we often scared about is actually diabetic peripheral
Yeah.
neuropathy. But just now, as I showed in the presentation, there are also other causes like idiopathic, or you have the carpal tunnel syndrome, or I don't know, generally for hypertension. This hypertension, yes, it disturbs the micro and macro vessels, because of the pressure. It also causes heart attack and also kidney disease because of it damages the vessels. But generally, compared to diabetes, right? Diabetes actually causes direct damage, and the inflammatory markers directly damages the nerve cells, right? So neuropathy is actually one well-known complication associated with diabetes, but not so much on hypertension. Hypertension more on blood vessels. So, but again, to your questions, it's the other way around. If let's say hypertension, will they get diabetic? From my experience and also from literature and also experience, I think diabetic eventually you will get hypertension. 70% of them will get hypertension. But hypertension alone, sometimes you may not get, there are people escape diabetes. If they have a good genetic and all that, they might not get diabetes, but they just remain on hypertension. So it's not really something that's associated with nerve disease, hypertension alone. But if you have hypertension together with diabetic, then definitely you need to be supplemented.
Yeah. I think the next few questions, they are quite similar to each other. So I will rephrase the question like this. So for the combination of vitamin B neurotropic supplements, is it really comparison between the combination and vitamin B12 standalone? So yeah, what are the clinical difference of adding this vitamin B1 and 6 just compared to a normal B12?
Mm.
I think their concern is like, should I start this combination or should I just start individual?
Mm.
Mm.
Okay. So okay. The thing is, okay, from the evidence, I think Gina talked a lot about B6. I think in my presentation, I think I had quite a lot of slides on B12 also. Okay, so they all are different. Okay, so if you see, remember my slide just now, one is the activator and another one is a regenerator. B12 is actually more on regeneration. Okay,
Yeah.
so B12 is also very important. I would say it's more for maintenance. That's why sometimes also people at this I see B12 most often at a middle stage or already when the disease already happened. I don't know who buys, what type of patients buy from the community pharmacy, but in hospital mostly like 10 years or 12, 15 years of diabetic, then sometimes in hospital practice, usually they start with neurobiome. I mean, B1, B6, B12 first. Then after that, when they have some symptoms and it progresses, then they'll go to B12 because you can actually go to higher doses of B12 like 500 TDS even.
TDS.
Okay,
Yeah.
so because you really want the regeneration of that nerve, because at that time the damage, you already see the damage because of the pain and all the symptoms. So so I would say that I think if you start diagnosing a person with diabetic, and then when they're symptom free, and you want to start a supplement that actually will protect their nerves very early, then definitely this neurotropic B vitamins is actually the choice. And later on, if you want to, it's considered like you actually amplifying your care, and then you can actually play around with this B12 alone or whatever, top up as you go on. It's just my experience that, yeah.
Yeah. Okay, I think the last question we will pass to Gina. I think many of us, many of the attendees actually ask, can need healthy people take the vitamin B complex for prevention purpose? Like I have no symptom of peripheral neuropathy, but maybe sometimes got, sometimes don't have, or I'm totally fine, but I want to prevent it because maybe my family have it. So is it recommended to take it?
I won't suggest high dose, really no symptom, because just now I mentioned about from the food source, really you can get B6 or even like beyond this all the B you are taking appropriately lah. Because some may be at different diets, some may tell you they go fasting with a special diet. So if you're already taking the food, fresh food and all that, I suppose that you won't have the symptoms. So if you really need, a multivitamin with a B complex in it, why not? If if sometimes some people have some injuries, for example, I encounter some patients just had a fall and so on, and then they start to have back pain or problem and so on. Then if they have enough, maybe they are recovering way faster. If not, then yes, you quickly supplement with B1, B6, B12.
Yeah. Okay, thank you for your answer, Gina. Okay, so because due to time constraints, so we will close this panel discussion currently, but then we will answer all the questions that's still posted on the question and answer and email to our the pharmacist or posted on the SwipeRx application. Okay, so no worries, your question will still be answered. So next, we will go to the poll of today webinar. This is a very simple poll. It's a feedback survey that for our understanding on to use the high dose of vitamin D and long-term use of it, and also what are your general recommendation after using this? But I think when we are waiting for the answer, right? I mean, maybe one question also quite many people ask, I think is quite important as well. Dr. Navi, in your clinical practice, how much loading dose you will use as an oral supplementation? The loading dose you will use like 1 tablet TDS?
Yes. I think as high as that, yeah, 1 tablet TDS, and yeah, BD or TDS. Actually, then only maybe the second or third month symptom relief, you can gradually come down to BD and OD. Yeah. So initially you need that, right?
Yeah.
Yeah.
So usually it's BD or TDS for the high dose. Then after
Yeah.
that, we maintain it just with 1 tablet
Yeah.
per day should be fine.
Yeah. So maybe you have to also ask the patient when they come back to you, then you ask the symptoms lah. Symptoms. Yeah.
Okay, so I've launched the webinar feedback poll. Next, so we'll proceed with the other information at the end of this webinar today. So thank you for both of the speakers, Dr. Naveen and also Ms. Gina, for your sharing for this on peripheral neuropathy. So dear participants, you may wonder how do you get the certificate, right? One moment, you all still haven't get the poll yet. Let me reshare. Okay, I have shared the poll already. Okay, please try to answer the poll. Thank you very much. I will start seeing responses. So to obtain a certificate and claim your CPD points, So make sure to attend the webinar for a minimum of 2 hours, okay? Because all the time has been recorded. So any information or discrepancy, you can email to SwipeRx team. After this webinar, SwipeRx will send an email to the address used for logging into Zoom, containing a link and instruction to download your certificate. Please expect the email within 7 to 10 working days after this webinar, as they need some time to consolidate the report. Thank you for your understanding. For any question or concern, feel free to reach out to us at hello@swiperxapp.com. So these are their official channels that they have Instagram, Facebook, TikTok as well. So feel free to scan the QR code on the screen and support the event. Okay, I think that's all for the session today. If you have done the poll, you may leave the webinar for today. Thank you for joining us. I hope you all learned something together today. Thank you very much. Have a good day.
SwipeRx.